Okay. So hopefully, there we go. Hopefully I can edit this out, but essentially the other live stream was echoing my voice in the back. I don't know if people were able to hear that, but on my end, I was able to hear a huge echo. I'm not sure why, because this is the only device I had open and was using. But so, welcome to the live stream. I'm Dr. Megan. I am a double board certified ICU doctor. Let me, I don't know if I can see the chat on this. Here we go. But I'm going to see if people who are on the prior live stream are able to file in. I'm going to have to remove that other one from my feed so people don't get confused. Looks like it's still active and I'm not sure why. Let me just change. I'm going to see if I can private this other one, but probably not, so people don't end up going to that one mistakenly. But again, I'm not sure why it had an echo. I'm hoping that the quality on this one is better. There, I was able to switch the other one, so hopefully, like I said, hopefully people don't get confused and end up in that one instead. All right. So, like I said, I hope when I upload this to YouTube officially, I'll be able to edit this first part out where I'm having issues. But anyway, my name is Dr. Megan. I'm the Intense MD. I am a double board certified ICU doctor who gives information about the ICU here on YouTube. I also use some other platforms, but YouTube is my main platform. So, today I'm going to talk about things that I think everyone should know about the intensive care unit and critical care in general. This is one of the core topics of my channel, but I wanted to make one video where I'll be able to interact with you guys and see if anybody has questions. And then of course at the end I will do a general ICU topic Q&A. So, like I said, I'm hoping I'm able to pull the chat up. If not, let me see if I can pull it up on my laptop. So before we get started, I do have a couple announcements for everyone. So one, the liver failure video, the third episode that was delayed, is going to be posted Tuesday at its normal time. I had to take a little bit more time to edit it. And right now, I cannot find my USB-C adapter to convert it, compress it, and then upload it to YouTube because I need my external hard drive for that. So if I don't find it soon, I'll just get another one this weekend. But I plan to upload that on Tuesday. So even if I finish today, I'll schedule it out for Tuesday. And that is the third episode about liver failure in the organ failure series. So there's a playlist for each organ, and then there's a big playlist for the entire series. If you haven't been able to watch that and you haven't seen all the episodes, they're all in one place. Over on my channel, there's a playlist called Organ Failure. The second update is I do now have an email list. Let me see if I can put it in the chat actually. So if you want to join my email list and I won't be emailing you a lot because I need to design my emails myself, and we see how frequent I am with uploading to YouTube. So I only plan on using it for big announcements and things that I just want to disseminate through the entire community. But if you want to know what I'm doing and anything new that's coming up for the Intense MD, then then feel free to join my email list. Just see sign up forms. Okay, so I'm going to put a link in the chat. So, and the reason why I built this email list is because I designed my own website and there was no other way to tell everybody at the same time than sending out an email. So, the third announcement is I now have my own website. It is a blog format. And there are some best of Intense MD videos that are embedded over there too. So if you just want to check out the highlights from this channel, there's about 3 videos that I pulled that are very popular or that I think are important. So you can watch them over there. And then I'll be updating it, probably on a weekly basis with new articles to read about critical care or other things adjacent to the intensive care unit. So let me just find the link to the email list. Here we go. All right. So link is in the chat if you have not joined the email list and you want to, and then this is my website. Okay. And I'm just going to be occasionally looking over at my computer I'm just adjusting this. I'm going to be looking over at my computer because that's where all of my notes are. But like I said, this live is just to tell you about what I think the average person should know about the intensive care unit and just basic things about the intensive care unit. If you want to know more about any of these topics, there are multiple videos about each of these that go into more depth. But just for the purpose of having all the information in one place, I figured I would do a live. So first, what is the intensive care unit? It is a unit in the hospital where the sickest patients go. So this unit has more resources to take care of a sick patient. We're able to do bedside procedures in the unit, and the nurses have a lower patient ratio. Typically, an ICU nurse will have 2 patients. If they're extremely ill or if they're on certain modalities of life support, such as ECMO, then this nurse only will have that patient. The patient's so sick that the nurse needs to give all their attention to that one patient for the day and cannot split their attention between multiple patients. And then, of course, you have specialized nurses who have training in critical care. You have physicians, intensivists such as myself, who have training in critical care. And like I said, multiple other resources and bedside monitoring. There are units in the hospital that do telemetry monitoring, but continuous monitoring for oxygen saturation, blood pressure, heart rate are done in the intensive care unit. So again, this is where the sickest patients end up going in the hospital. So the next question is, what is an intensivist? And this was my very first video on this channel. I am probably going to re-record it at some point because the quality is so poor. And of course, with my first video, my delivery is not very good either, but I will leave that there forever just for everyone to remember where I came from. But an intensivist is a physician who specializes in critical care. We do additional training after our residency program to learn more about critically ill patients, how to do bedside procedures, how to manage the ventilator, some more advanced modes on the ventilator. So these are physicians and they can come from multiple backgrounds. I was initially trained in internal medicine, but there are also people who are trained in emergency medicine, surgery, anesthesia. So you can come from a multitude of backgrounds for people who want to do critical care. So intensivist just specializes in the ICU. Most of us only work in the intensive care unit. There are some people who do internal medicine and then do pulmonary and critical care. So they will see patients with lung disease in their clinic outside of the hospital or have weeks of consulting service on the pulmonary service where they will go to other floors and give recommendations for people with severe pulmonary disease. So that is what an intensivist is. And of course, if you have any questions, feel free to drop them in the chat. But like I said, I will also be doing a Q&A later on at the end of this video. And thank you. This is my first live. I've been practicing live over on TikTok, but I figured since YouTube's my main platform, this is where my audience is, I would do an official live here. So as I discussed earlier when I was discussing the intensive care unit, something else to know is it is a multidisciplinary unit. So we have a very big team who takes care of critically ill patients. There's a doctor, there are sometimes nurse practitioners and physician assistants who work alongside of us, or trainees at different levels of their medical education, like interns, residents, and fellows. There's also the critical care nurse, respiratory therapist, a dietitian, and then sometimes we'll have palliative care help, physical therapy, occupational therapy. The list goes on. Patients who are critically ill need a lot of support to recover. So the team can get very, very big. And we also have multiple consultants who may be seeing a particular patient. I currently work in a surgical unit, so we always have the surgical team. Sometimes there are multiple surgical teams, and there are also other physicians such as cardiology, nephrology, infectious diseases. All these doctors will come and give their expertise so we can take best care of this patient. Can I explain why? Yeah, I'm actually going to discuss code status soon, so we'll get there. But that's a great question. So we'll definitely be talking about code status after I talk about life support, because I find it helpful to talk about life support first. So the next thing I want people to know about the intensive care unit is what life support is, because a lot of people either think it's just the ventilator or they think that life support is treatment for an illness. So life support is exactly what it tells you. It is there to support somebody's life. It's not a treatment, it's not a cure. The purpose of life support is to support somebody's body while their body's trying to heal. The life support devices do not reverse any disease process, and the body still has to do work on its own. There are, and like I said, there are some treatments that people may be receiving, such as if they have sepsis, they might be getting fluids, they might be getting antibiotics, but the devices they're on are not treating them. The body still has to do its job. So unfortunately, sometimes people will still pass away despite being on life support because their body is just so weak, it can't overcome that illness. So the different types of life support are the ventilator for people in respiratory failure, and this is probably the most common in the ICU. People are on the ventilator for multiple reasons. I made a YouTube video about this, and this is probably another one I'm going to end up remaking since it was an early video. I'm definitely probably going to pull a Taylor Swift and re-record some of my early stuff. But the ventilator is the most commonly used life support in the ICU, I would say. Closely followed by vasopressors. Even though they're not a device, they're a medication. They're a medication that supports the blood pressure. It's still supporting somebody's life, and without it, the patient would most likely pass away. And along with that are another type of medication called inotropes, which helps the heart squeeze. So those, I'd say those two are the most popular. We also very commonly use CRT, continuous dialysis, in the ICU for people who are very sensitive to changes in blood pressure. They're not able to tolerate hemodialysis, which can cause a lot of shifts in fluid over time. But um, but they they are commonly used. The continuous dialysis is commonly used in the ICU, especially if somebody has a high level of acid in their blood, a lot of potassium, things like that. Um, and then, of course, we have the mechanical circulatory support devices like the balloon pump, which helps propel blood forward in somebody in cardiogenic shock. There's the Impella, which is a temporary left ventricular assist device, and this is used when somebody's left side of their heart is failing and they need the extra support to propel the blood to the rest of the body. It takes the blood out of the left ventricle and puts it into the aorta in the event of extraordinary heart failure. And there are also permanent versions of LVAD, such as the HeartMate 3 is a very commonly used LVAD. I think the earlier ones, like the Heartware and the HeartMate 2, are no longer implanted. It's just the HeartMate 3 at this point. But some people will be on technically chronic life support with a permanent LVAD. And then finally, ECMO, VA ECMO, and VV ECMO are two modalities to support somebody's life if they have severe respiratory failure and they need help with oxygenation beyond the ventilator. They would need VV. Then they may need, shoot. Are you guys able to hear me? Because my thing just said it was reconnecting. Anyway, I was just talking about VA ECMO. So if somebody is in severe heart failure, severe shock, then they might need to be on VA ECMO. And there's a lot of criteria for ECMO because it is such a massive undertaking and it needs to be a bridge to something, either recovery or transplant. People cannot be on ECMO for the rest of their lives. Thank you. And then, do I have any good books for internal medicine, excluding Harrison's? Um, I'm trying to think of what I used in residency. I used the Mixapp books a lot for the individual systems. Um, Harrison is kind of the big, I'd say gold standard for internal medicine. But I did like to supplement with the Mixapp books and just kind of spot reading on up to date. I'm looking at my bookshelf right now. I don't have internal medicine books anymore. I just have critical care medicine books. I don't know if my husband has any. He's not home right now. But I had Harrison's, and I did. One time I told my program director that I was using it to press water out of tofu, and he did not find that funny because they're such big books. Sometimes you need them for other things. Okay, so moving on to code status. So code status lets the medical team know what you want in the event of a medical emergency. So this is typically if you're admitted to a hospital or any healthcare facility, they will ask you what your code status is. If they don't, you should tell them what your code status is. So this lets them know if your heart were to stop, do you want CPR? Do you want attempts at resuscitation? Do you want to be shocked if your heart's in an abnormal rhythm? And if you were in severe respiratory failure and had respiratory arrest, then do you want to be placed on a ventilator? Because these are the two reasons why a code blue would be called in the hospital for an adult. Usually a pediatric code is not called a code blue. I've been in hospitals where it's called a code white or I don't know if I've heard it called a pediatric code blue some places, but I've honestly not worked at many hospitals that also have pediatrics. That's usually a completely separate hospital for the children's hospital. But in adults, a code blue means that either their heart has stopped or they stop breathing, which will eventually lead and very quickly lead to their heart stopping. So if you want all of those things done, then you are a full code. That means you accept CPR, shocks, anything we need to do. Sometimes we need to do urgent bedside procedures. Um, there's a lot of things that happen all at once during a code blue. And of course, being placed on the ventilator for life support. That's pretty much saying you will support any type of life support measures that you're a candidate for and that we can offer you. The next is a do not resuscitate, and this means that you do not want to be resuscitated in the event of having your heart stop. You just want to die naturally without any interventions. Some people say without heroic measures, which I don't really like that term, but that is also something that people will use. And then there's also a do not intubate. So this is a situation where somebody might not be a DNR, but they don't want to be placed on life support in terms of the ventilator. So some situations where somebody might, so you said explain why a patient would be just DNR and not DNI. So a lot of times in these situations, sometimes they'll put that code status in if somebody's already on the ventilator, but I think a DNR is more clear. If somebody's on the ventilator, not going to come off the ventilator, and the decision maker has changed the code status to DNR. Some people might not want to be resuscitated if their heart stops, but if there are other things that we can do to prevent that from happening, including life support, then they may accept those measures, such as cardioversion, shocks to the heart, or being placed on a ventilator, or receiving vasopressors. So they may say, if I die, I don't want to be attempted at resuscitation, but if you can do everything up to that to prevent my heart from stopping, then I accept those things. So they would accept being placed on a ventilator. And sometimes when people are very critically ill, I'll have a discussion with them and say, excuse me, the medications we give you to put you on the ventilator might cause your blood pressure to drop to a dangerously low level and your heart to stop. So I have seen that happen before. We do a lot of things to try to prevent that. And like I said, we have some medications that can try to increase the blood pressure. But sometimes a person's pathophysiology might lead them to, just if we take away any compensatory mechanisms that they had by giving them these medications, then they crash very quickly and we're not able to resuscitate. And sometimes people are in such respiratory extremis that it's already putting stress on their cardiovascular system. So I hope that answered your question. Let me know if you need any more clarification, but that is sometimes why there'll be a DNR and not a DNI. If somebody's a DNI but not a DNR, usually I have a conversation with them and tell them that if we don't put them on the ventilator in the event of a respiratory emergency, then it will most likely lead to their heart stopping, and it would be very challenging to resuscitate them without being able to oxygenate them appropriately on the ventilator and be able to ventilate them appropriately. So there are things we can do, such as non-invasive positive pressure, that's the CPAP and BiPAP mask, that can temporize them if they're in extreme respiratory failure and there's higher flow oxygen. There are some things we can do to try to prevent an intubation. But if they are in respiratory arrest or in any type of extremis, we may not be able to turn them around without placing them on life support. And then in that case, running a code on that person does not have a benefit because the chance of them being resuscitated is low. And even if they were resuscitated, it's not fixing the underlying lung problem and they still need mechanical ventilation. So sometimes there is a little bit of a mismatch there. And so we'll have conversations about if this happens, then these, this is the possibility. And then finally, for code status, you can also be comfort measures only. So DNR does not mean do not treat. It simply means that if anything were to happen in an emergency situation, your heart were to stop on its own, you don't want anything done. But it doesn't mean that you don't want the condition you came to the hospital for to be treated. Like I said, there are some people who will accept types of life support and want to continue to escalate care, but if these things fail, they do not want to be resuscitated. So that is a little bit of a difference. So if somebody doesn't want anything done, they don't want to be resuscitated, they don't want treatment. Sometimes they'll say, I don't want any procedures done on me, I don't want my labs to be drawn, I don't want to be poked anymore, I just want to be left comfortable. So that's when we transition the focus of the patient's care from active treatment to making sure that they're comfortable. And this is in the setting of somebody having a terminal illness. So that is also a possibility. There are many hospitals that work closely with hospice agencies, and they will come to the hospital, come to the bedside, and either do inpatient hospice there, or if somebody's able to, and I had a patient that this happened to this week, they were able to go home on hospice. A lot of times in the ICU, it's challenging for them to go home on hospice because usually they are attached to so much life support that if we were to turn that off, they would most likely pass away before they got home. And we don't want somebody to pass away while they're en route to their house. So if we don't feel like it's a safe discharge, we don't feel like it's safe to move them because we don't want to move somebody who is in the active dying process. Even sometimes if somebody is on hospice but they're more stable, we might move them out of the ICU to the general hospice floor. But if we feel like they are in the process of passing on, then we don't move them because it's just not appropriate to move somebody when they're in that condition. So if you guys don't have any more questions about those things, I'm going to move on to the next kind of things I'd like people to know about the ICU. And like I said, I'm also going to have a Q&A at the end if you guys have any kind of off-topic questions, although I have been kind of answering some of them as we go along. So the next thing I want people to know is who they want their medical power of attorney to be. And this is separate from a legal power of attorney. A medical power of attorney is the person who will make medical decisions for you if you are not able to. There are some situations in the hospital when people might be too sick to speak to us because many times when somebody comes in critically ill, they're also very confused. And that's just something called toxic metabolic encephalopathy. But they come in, they're confused, they might be very weak, they might be in a different state of consciousness. So we're not able to have them make an informed decision. You can't be asking someone in that state what they want in terms of life support and advanced measures. So that's why we look to see if they have anybody identified as a medical power of attorney. And also, people who are on life support on the ventilator, typically sedated, so they cannot speak to us. So we rely a lot on who their medical power of attorney is to update them about the situation, tell them what the clinical plan is, and see if that is in line with what the patient would want for themselves. So think of the medical power of attorney as your spokesperson. They know what you would want. They know you very well. You have told them what you would want in different situations, and they're just there to be your voice. So if you do not have a medical power of attorney, then it will go to your next of kin. And the thing I want to emphasize is this person who is your next of kin is your medical decision maker, no matter what type of relationship you have with this person. So, for instance, and this is for adults, so people over 18. If the person is under 18, it's usually a parent or guardian. But if you're an adult and you're married, it is your spouse. If you are legally married to this person, they are your decision maker. It does not matter that you were separated for 15 years and haven't seen them. If you are still legally married, you are not divorced, then they are your next of kin. Same for adult children. It doesn't matter if you haven't talked to your kids. If they're over the age of 18, you are unmarried, then they are your decision maker. If you are unmarried, you do not have children, you're over the age of 18, and your parents are living, then your parents are your next of kin. So, again, it doesn't matter if you are estranged from your parents, you don't have a good relationship with them, you don't speak to them. Legally, they are your next of kin. So, this is why I think it's important for people to assign a medical power of attorney because you are selecting that person. You are telling the medical team who you would want making your medical decisions. So, it should be somebody who knows you well, somebody who we can easily contact and someone that you have spoken to and told them what you would want in different situations. So, something to go along with that is making an advance directive or living will. So, these are legal, this is legal paperwork. It's not, um, it's not a physician order, but you can think of it as a script for the person to go off of and kind of a disaster plan. So if you have, attended school, worked anywhere, typically you would have a fire drill and a fire exit plan. You hope you never have to use that. You hope that your home or your business or place of employment never catches fire, but you still need a plan if things happen. Because you never know when you're gonna become critically ill or if you're in an accident. A lot of younger people do end up in trauma ICUs. So, it's always good to know what you would want in these different scenarios. So, an advance directive will kind of list out it's very vague, which is why the medical team cannot use it as a piece of medical paperwork, but it will tell the person who is assigned the medical power of attorney if the patient wants to be resuscitated, if they want life support, if they want certain measures and um, escalation of care in different scenarios and what they would consider a meaningful quality of life. There are some states that have a form similar to this, but it is a physician's order. There are post forms or most forms, which are the same thing, just different states have different names for them. And a physician sits down with a patient and they will say, in the event of these situations, what would you want? And it's check boxes, yes or no. Sometimes there's room for comments. Then it asks you to assign a medical decision maker and an alternate medical decision maker. And then the one state I worked in that had the pulse form, there was also a box that said that the person you selected can override anything that you've checked off before. So if you said you wanted to be a DNR, if you check that box, the person can override it and make you a full code. So, and then it's signed by the patient, it's signed by the physician, and that is considered part of the medical record. I am not sure why this is not available in all 50 states because it's very helpful to the clinical team. And this is typically something that is done in an outpatient setting where people can think clearly. There's no disaster happening, there's no medical emergency. So people have time to think and consider what they want. When I'm approaching a patient and their family, typically the patient is in some type of crisis and we need to make a decision very quickly. And it's challenging to make these decisions when somebody is so sick in such a short period of time. So, this is why I emphasize that these things should be taken care of before anything happens. Hopefully, you make an advance directive, living will, sign a post form, and nobody has to use it for years to decades. But it's still good to let people around you know what you want in this setting, and also good to know who is making your medical decisions and if that's the person that you want, who you would select. So that that's kind of what I think the important things are to know about the code status, next of kin, advance directives, and post forms. So does anybody have questions about any of that? Because I know that was a pretty lengthy discussion. So that actually is what I wanted to talk about today as my core topic. So if you have any questions about anything related to the ICU, I'll now start the Q&A portion of this. Um, and I'll just kind of take a couple minutes to refresh or go back over what I talked about earlier in case you just joined us. But feel free to leave any questions below. So I started off with announcements about one, my next video is coming up on Tuesday. I know I missed this week. I had some issues with my tech side of things, but it will be up on Tuesday. It is the third episode of liver failure in the organ failure series. And I put a poll across multiple platforms about which organ system people want to hear about next. And the heart has won by far. So I'll be recording heart failure hopefully this weekend. But I am going to do some videos in between to break things up just because I think that talking about the organ failure topics might be a little overwhelming and just a little monotonous. And then the second announcement was that I do have an email list now. You can sign up for it. I put a link up in the chat. So if you scroll up, you can probably find the link to that. And then the next link is my website that I launched at the beginning of this month. So it is a blog style website. I do also have some of my curated videos from my channel, but I will be updating that probably once a week or so with articles and just interesting things I would like you to know about the ICU. So if you're more of somebody who wants to read things than listen to videos, it's just kind of good snapshots of things I talk about here on my channel. And like I said earlier, if you join my email list, I'm not going to be sending out emails all the time. I have to make them myself. I have to create them myself. And I don't want to send out something if I have nothing to say. So the only email I've sent out so far was my website launch at the beginning of this month. And then I don't know what's coming next. So I don't know when I'll be sending emails. But today's topic was just, I was asked generally what I want people to know about the intensive care unit and critical illness in general, because I went across all of my platforms and asked if you can ask an ICU doctor anything, what would it be? And somebody asked me, what do you think the general public should know about the ICU? And then the second part of that was misconceptions about the ICU, but I'll be making a separate video about that. So just to give the highlights of today, one, what the ICU is, two, what an intensivist is, that's me, and then that the ICU team is multidisciplinary. We have many people, many disciplines taking care of one critically ill patient. Then I moved on to talk about the different types of life support. I have made a YouTube short about this recently. I have longer form videos about this. So there are a lot of things on my channel, a lot of content across my social media platforms about the types of life support. And then moving from that, we talked about code status and what somebody would want in a medical emergency, which kind of goes along with knowing what life support is out there. Because it's hard to make a decision about what you want if you don't even know what's available to you and what those things entail. Because a lot of people say they want everything done or they want everything done for their loved one. And then we take the time to resuscitate, do procedures, hook them up to machines, and then they walk in the room and they're like, "Oh my goodness, I didn't know that like this would be it," because most people don't know what an ICU patient looks like when they're on all of these devices, and it's very overwhelming. I remember when I was a medical student and an intern, first rounding in the intensive care unit and seeing how sick people can truly be, how sick the human body can truly get, and what types of support they require to stay alive. So that can be overwhelming. So I think it's important for people to know what's available out there and what it entails. And then moving from code status, we talked about medical decision makers, whether that's your medical power of attorney, that is a person that you have assigned and filled out legal paperwork saying that they make your medical decisions, or your legal next of kin. So if you don't have any paperwork, this is, and it varies state by state, but this is the next person in line to make your medical decisions. Something I did not mention about next of kin is, so say we have a patient, they've they're still legally married, but they've been separated for 15 years. And then we go to their estranged spouse and say, "Hey, this person's super sick. They don't have any paperwork assigning anyone, so you're their medical decision maker." That person can say no. That person could say, "You know what? I haven't talked to them. I don't really have a relationship with them. I don't feel comfortable making their medical decisions." We don't force that person to make medical decisions. What they can't do is say, "I don't want to make their medical decisions, but I'm going to assign that person." They can't pick the next person to assign. If the patient didn't assign anyone, they can't say, "Oh, it's not me, but I want it to be them." It just goes to the next person on the list of next of kin. So again, this varies state by state, but typically it's your spouse and then your adult children and then your living parents. So if the patient has adult children who are still living and their spouse does not want to make their decisions, then it goes to the adult children. And whether the children need to be in the majority or unanimous depends on the state. That does vary state by state. The state I currently live in, it just needs to be a majority, but we do like all the children to agree just because it's just better when everyone is on the same page. So if it seems someone's a little hesitant, we try to identify why that is and make them, more comfortable with the decision that everybody's making, because we don't want people who are, related to each other and making these difficult decisions to have any resentment between siblings because of a decision that's been made. And then finally, I also talked about making an advance directive, a living will, or if your state has one available, a POLST form or a MOST form, which I wish was available in all 50 states. So that's kind of the overall picture of what I think people should know about the ICU, just in general. These are core topics on my channel and on my other platforms. These are things that I bring up on a regular basis. So I do have a lot of content about this if you want to learn more. I do have an entire playlist about life support. I also have a playlist called ICU Basics. So that's just kind of similar to topics I talked about today, just basic things that I think the general public should know about the intensive care unit. So if you guys have any questions, just leave them in the chat. I'm happy to answer them. I'm going to try to go live probably about once a month as my schedule allows, because it's very challenging to find time to come on live that is, I guess, good for everybody else. A lot of times my days off are weekdays, and I know a lot of people work. So I'm going to try to find time to come on live more often. But if you have any recommendations for what you want to hear next in a live, I know somebody had commented on my poll and said they wanted to talk about burnout and moral injury. So that's a great topic for live. I think it would be cool if I had some other providers guest with me and do a multi-person live. So maybe I'll try to find some people who want to talk about this topic with me. But if you have any recommendations or any suggestions for videos or lives or anything, I'm pretty open to it because I want to give you the information that you're looking for. Um, so with that, thank you so much for watching my first live. This went pretty well, minus the technical difficulties in the very beginning, but I don't know why I thought I was going live from my computer because I didn't even have YouTube open on my computer. It was very strange. Um, but yeah, so if you guys don't have any more questions, I hope you guys have a good day. And like I said, look out for the liver video on Tuesday. I'm also going to be um, publishing shorts throughout the week. So keep an eye on my channel because there's going to be a lot of activity. And in my descriptions for any of my videos, there's also a suggestion box and a Q&A form if you did not find what you're looking for here. And with that being said, I hope everybody has a good day, and hopefully this live will be available to view on my channel very soon. I'm going to see if I can edit some parts out that I was having issues, but if not, it's fine. Thanks for coming.